Sorry, Tony, I have to take you down to the bottom of the pyramid now. Anyway, fantastic lecture. On behalf of Indian ophthalmology, I have to offer one apology to you, though. To listen to you, this hall should have been overcrowded, but we have an embarrassingly poor attendance. Apologies for that. So, switching gears from the horizons of what is happening in gene therapy for some of the rarest forms of corneal disease to what is out there in the remote, rural, and vulnerable communities of countries like ours. This is the picture of Majuli Island, a river island on river Brahmaputra. You can reach there only by boat. There is no road connectivity. About 7-8 years ago, in partnership with one of the ophthalmologists in Jorhat, a vision center was inaugurated, a primary care vision center. When I attended that inauguration, I thought we have finally arrived. These are the kinds of communities that require our attention, more and more of our attention. And River Brahmaputra, going on the boat, crossing the river, was a phenomenal experience.
Pranamo Brahmaputra, Namami Brahmaputra.
So we often hear the world, all over the world, the term universal health care. That is the aspiration of every country from America to Afghanistan. Comprehensive care, commitment to quality, taking as much care as possible closer to the doorstep of the people who need it most. And in our country's case, it's the remote, rural, and rural communities where 70% of India resides. A continuity of care, not just eye camps, with active community participation. If you look at the primary care, it can be divided into two categories. One is community-based, the second is center-based. At the community-based care, we are looking at what we term in our institute's terms as vision guardians. These are healthcare workers who act as volunteers on our behalf, keeping an eye on a population unit of 5,000 people to promote eye health, help in screening programs, making referrals of those people who have any vision problems, and keeping an eye on the two vulnerable age groups post-operatively, the pediatric and the geriatric, and using tools like this, inexpensive, simple tools that will allow you to determine the presence or absence of a possible refractive error. These are then linked to the next level of primary care called a vision center, a concept that we have developed about 27 years ago. And I'm delighted that this has become a catchword all over the world, and thousands of vision centers have proliferated across the world. With a one-year trained technician staffing the center who completed higher secondary education, then the training as a technician, quite often recruited from the local rural communities from disadvantaged families, and giving them a profession. It's a predominantly hands-on training with basic theoretical teaching. They are empowered, and they have career advancement opportunities, with a couple of them in our institute, in fact, completing their PhDs at the University of New South Wales. So there are two types of vision centers that we have evolved over the past 27 years. The conventional ones, where you detect a potentially vision-reducing problem or a vision defect or sight-threatening problem, refer them appropriately or treat them appropriately. Whereas more recently, in the past 5-7 years, we have come to futuristic vision centers, which can not only detect, it will provide follow-up care for a number of procedures, treat certain number of diseases through teleconnection, refer, and reassure the patients. And we have also added a number of different tools, inexpensive but high technology, to detect refractive errors, to be able to do visual fields, and to take retinal photographs and pass it on to the command center at the tertiary level to get the diagnosis and advise the patient appropriately. These primary care centers are part of a system with universal access. In our cases, the primary care vision centers are available to everybody in those villages at no cost. Everybody is screened free of cost. And if all that they require is a pair of glasses, they are prescribed right there and dispensed. If they require referrals at the next level, 10 such centers in our system are linked to a secondary level center where there are ophthalmologists, the care is provided there, and rarely they have to be referred to a tertiary center. And when you look at some of the studies that are published by others, have shown that indeed the case finding and treatment initiation costs are far less in the case of vision centers compared to ICAMs and other approaches. And we also have come up with some innovations of appropriate referrals by triaging these cases. If you say green, they don't need to be referred at all. Yellow needs to be referred within a couple of weeks. And red is immediate referral as an emergency. By approaching this, we have reduced the need for referrals significantly, saving a lot of costs for the patient and their families. The second is the comfort to the patient. And the third, in the modern day world, when we talk of environment, carbon print. It goes beyond all this. It's not just simply refractive errors and giving a pair of glasses or identifying a cataract. Here is a little girl in a remote rural community in Andhra Pradesh who presented to our vision guardian with this appearance. She has immediately taken this kid to the nearest vision center, and the vision technician suspected a possible congenital glaucoma and referred them to the next level. An immediate intervention at that point resulted in what you see on the right. A complete clearing of the cornea, restoration of sight, and we have averted a lifetime of blindness for this kid. And here is another kid who, again, the vision guardian identified to have a white spot in the eye, referred to the vision center. The vision technician could suspect a possible retinoblastoma, immediately connected to our oncologist. It required significant effort from the oncologist, the vision technician, the sarpanch of that village to convince that father for enucleation of that eye and subsequent chemotherapy and fitting with artificial prosthesis. So these are the magical things that can happen at the primary level if we create the proper system of primary eye care in our rural areas. What we have found out from our experience is if you have proper primary care centers with proper infrastructure, well-trained technicians, connected to appropriately placed secondary centers, 80 to 85% of all vision-threatening conditions can be taken care of right in the rural areas. There's no need for any of these people to travel to our big cities with considerable cost savings, and the macroeconomics is even bewildering. But the key factors for the success of primary eye care include proper infrastructure. Like, for example, our vision centers would have the same kind of slit lamp that we have in our Hyderabad campus. And the second is the quality of training of the technicians. It's not just employing any technician and leaving them there. They have to be properly trained. Assure good spectacle supply, the supply chain of very important. Connectivity with the technology, and it should be part of a system. If you build vision centers in isolation, they languish unless they are connected to the next level centers. We now have 263 vision centers as of 4 days ago, and they are rapidly expanding, connected to 22 secondary centers, predominantly in 3 states with a little presence in Karnataka. So, ladies and gentlemen, what I want to say is, while we celebrate tertiary care, we celebrate research breakthroughs in a country like ours, we have to constantly innovate ways of reaching out to the people who are out there living in the remote rural and tribal areas, the very vulnerable populations of our country and many developing countries. In fact, the same applies to many developed countries. Some American friends ask me, how do we replicate this? I tell them, you have all the pieces in place. You just have to rejig your health system and create appropriate structure. Thank you so much.
Thanks, Dr. Rao, for a wonderful presentation and taking care of millions of the patients in an innovative way and economically affordable to the masses of India.